Good evening, everybody. Thank you for joining us tonight on Taylor Tuesday. I've had a little bit of a hiatus. I've got to take a few weeks off. Had my good friend Dr. Batya and Dr. Schneider covering, but I didn't want to miss tonight's presentation. We have a real rock star who's going to be talking to you all later. So anyway, I barely made it here in time, everybody. I know that for those of you who know me, might find it hard to believe, but I was out tonight actually teaching Bible school. My friend asked me to talk about Passover, so I got to talk about the holiday for these Bible school students here in Whitefish, Montana. So again, welcome everybody to Taylor Tuesday. This is something we've been doing for quite some time. We at Taylor are very proud of this educational programs that we have for our members. And I just want to let you know that not only do we provide these programs for you because we want to help your practices, we archive them. So you can show them to your staff and to other colleagues who did not get a chance to attend because they were busy or they had some things going on. So if you go to our website, www.taylormedical.com, and go into the upper right-hand corner where it says webinars, and you see it's highlighted with those red arrows so you can't miss it. All of the webinars that we've done are archived, and that allows you to view and see any of the programs that we've done and make sure that you can educate yourself. You know, a lot of people don't know what a GPO is, and neither did I till I got started with one. Taylor Medical is the only Medicare 60/40 safe harbor GPO in the podiatric space. We were started probably 2014, 2015, and then went live as a company at the end of 2016. During that time, we've grown significantly. We touch somehow, some way, almost 4,800 podiatric physicians and surgeons and their staff. We've expanded to other specialties and it's continued to grow. We started out to try and help doctors with their practices. We wanted to provide them with quality products at a good price. We noticed that the market was very fragmented at the time, but it's turned into something more than that. Taylor Medical is a company that has a vested interest in your practice. We not only want to find a widget at a good price, we want to teach you how to implement these widgets into your practice. You'll be hearing about something today on this evening's program that'll be something that you can add to the armamentarium to be able to provide quality care for your patients. So, you know, one of the things with Taylor is, first of all, it's free. If you're not using it or at least giving us an opportunity, I think you're missing the boat. We have a very dedicated team that will work very hard at doing a free cost analysis for you. It's very, very simple to do a cost analysis. Depending on the vendors that you may be using, it may be as simple as pushing a button and running a digital report from your from that program to see what your products have been done. You could send us, if you need to, just send us receipts, send us invoices. Basically, we do need the name of the vendor, the description, the manufacturer or the SKU, and the unit of measure and the price, and then we'll put it into an Excel spreadsheet if you haven't provided one, and we will make everything available to you by doing a cost analysis. I like to call it apples to apples and apples to oranges. I say apples to apples from the standpoint if we just compare what you're purchasing now without making any changes. You know, for example, our big med-surg partner is Medline. Many people don't know, but Medline's generic Band-Aid is Chloride. Chloride is in every pharmacy, every shopping center around the world, and you may be using a product and spending significantly more money. We are looking to give you quality products at a quality price, but we want to teach you how to implement things into your practice. So I think that it'll be interesting to hear about our next speaker. I do want to welcome Ashley from Ascend Medical. Is it Ascend Pharmacy? And she is the head pharmacist She's the one who makes all the concoctions that'll probably be helping all your patients. But I'm going to let Dr. Bhatia tell us a little bit about Ashley Dick and at the PharmD. And I would be negligent if I didn't mention Dr. Andy Bhatia, who has been a dear friend to me for a very long time, was one of our founding partners when we started Taylor Medical. And Andy is the current president of the Practice Management Academy. He's been giving back to this profession for a very, very long time. And I really appreciate him helping to co-host this evening's program. So, Andy, I'm going to turn it over to you.
Okay. Thank you, Ira. It was a very kind introduction. And welcome, Ashley. Welcome to everybody. And before we get rocking and rolling here, I'm going to give you guys a little bit of an insight into our speaker today, Ashley. She is the director of pharmacy at Sen Pharmacy. And what she's going to do is she's going to discuss how compounded medications can be utilized in your treatment plan for your patient to improve your clinical outcomes. So as the only pharmacy in the country which is dedicated to lower extremity care, she will explain how their formulary and works and how to incorporate it into your practice. Dr. Ashley is a graduate of Samford University Pharmacy School. She completed a community care practice residency with a focus on compounding through the University of Tennessee. And for 13 years, she was the director of pharmacy for a compounding pharmacy in Mount Juliet, where she grew the business into a diverse practice, offering services in bioidentical hormone therapies, autism care, and pain management. As a result of those efforts, she was awarded state and international awards for innovation and leadership. It's great. So we really have an esteemed speaker with us. As a result of her efforts, she also spoke nationally on the subject and has been speaking nationally on the subject of compounding. She's currently licensed in about 16 states. And for the last several years, her focus has been on wound care and nail infection compounds, utilizing DNA-guided therapy to create patient-specific treatments. Ashley joined the Ascend team in 2020, early 2020, and has been working to build a clinically sound formulary that has produced positive outcomes for their patients. So we're very excited to hear what she has to say. And with that, Dr. Ashley Dick, I'll let you take it away.
Thank you so much for the introduction. Good evening, everyone. I am going to kind of address compounding tonight as though you probably have never heard of it. So if you have and you've utilized it in your practices, please forgive me for that basic level. I'm going to explain it to you, but I think you might still learn a few things tonight as we go over some of the formulations that we have created. Some of them will be very common to what you've probably already utilized, but there are some out there that we have created specifically for Ascend and are pretty unique. So we'll just dive right in and see what we got here. These wonderful gentlemen have already kind of covered the fact that Ascend is the only pharmacy in the country that is dedicated exclusively to lower extremity complications and treatments. So we have, as we go through the evening, you'll see that we have everything from pain management to nail infections, wound care, and more. We are a member of the Professional Compounding Centers of America. The importance of that is that, one, we have access to the most cutting edge bases, which gives us opportunities to do things that other pharmacies cannot. We also have the highest qualities of chemicals. And then also PCCA has a team of consultants so that if I don't know the answer, and I'm happy to tell you when I don't, that I have a team that I can count on to go back to help me research to find the best options for those patients that we need to find a solution for. And with that, we also have a network worldwide of compounding pharmacists, so we can find out things that people have tried in other countries that maybe we haven't quite applied here in the U.S. yet. I have been a compounding pharmacist for about 20 years now. It's what I went to pharmacy school for. It is what I love doing, and it's about all I've done since I graduated. So I definitely kind of have my roots here and love it. So jumping right on into our formulary. We'll start off with topical pain management and kind of just a generalization of the topical pain managements that we utilize. Most of ours are creams, and we use a liposomal base. The importance of that versus like a PLO that you may have utilized in the past, or even some of the covered compounds that can be covered by insurance. Those typically are going to just kind of sit on the surface. They're not going to penetrate deeper into those tissues and into the lipid barrier, through the lipid barriers, and get to the tissues where we want them to work. So that's a very important part of making sure that a topical pain compound will work, is the correct base selection. Also, one of the benefits to topical pain management is it gives us an opportunity to give patients who may not have been able to utilize things like an oral anti-inflammatory the opportunity to be able to do that, because we typically see reduced side effects, if any, because we're not getting a lot of systemic absorption of those creams. Kind of stays really localized to the tissue you're applying it to. So patients who may have a GI ulcer who can't take oral anti-inflammatories, or I've even had patients who have been on blood thinners. Obviously, you still want to utilize those with care and caution, but I've had patients who could definitely use those that would have been contraindicated in any other situation. So jumping right into the pain and inflammation formulation, we typically do a Diclofenac Lidocaine combination. We do offer a couple different strengths of that. As compared to things, something like Voltaren, Voltaren is that 1%, is available over the counter to the patients. But here you've got triple the anti-inflammatory strength, as well as that addition of the lidocaine to it. A little known fact is that this is a great great option for patients with bone pain. Opioids do not work on bone pain very efficiently. We have no opioid receptors in the bones. And so we have seen patients that have had tumors in their bones, metastasis, that were able to utilize these with better results than oral opioids. So gives you an opportunity to, one, not have to utilize something that's strong. You actually are significantly improving patient care as well. Our Fibromyatosis Cream, again, taking that same basis of the Diclofenac and lidocaine and adding the verapamil in there. The verapamil are in the formulations, you'll see them several times throughout the night when we talk about fibromas, that verapamil actually works by a couple of mechanisms. One, it's thought to be able to slow the progression of a fibroma growth by preventing the release of collagen and fibronectin from the cell. And so we're able to actually slow down the progression and the growth of the fibroma. The second way that verapamil can also work is, by increasing the production of collagenase. So it's actually going to help to break down that tissue and, apologize, and help to remodel the excess collagen that was there. And so over time, we do typically see a reduction in the size of the fibroma and improvement in your patient's pain. The plantar fasciitis formulation we have is a combination of amitriptyline, baclofen, and ketoprofen. Pretty self-explanatory. So we've got an agent in there for the neuropathic pain, as well as any muscle tension and tightness, and that anti-inflammatory. We have a gout formulation that works great for our patients. Initially, when we created this formulation, indomethacin was our drug of choice for the anti-inflammatory. But unfortunately, over the last couple of years, indomethacin's been on a nationwide back order. So to just simplify the process, instead of having to contact the physicians all the time, we just went ahead and changed that formulation to diclofenac. In the event we see indomethacin come back off that back order, it's definitely would be something we switch back. But we do have that anti-inflammatory, the anesthetic effect, and then that colchicine there to help break down the uric acid. One formulation that's pretty unique to Ascend is the Nitroglycerin Ointment. Several years ago, I had a physician bring this to me. And honestly, was kind of surprised. I had never seen nitroglycerin utilized for tendonitis. But there are some studies out there that show that it's being used in Europe and Australia as a patch. You're cutting the patches. So this gives the patient a little bit more control over the application of it. But the nitroglycerin is thought to increase the nitric oxide in the area, which can help with the healing and of the tendon, as well as strengthening it. So the one of the negatives with the patch utilization is that patients typically see the side effects with potentially lower blood pressures and headaches. We have not found that to be the case with this ointment. We also have a formulation for Rainoist, where we're increasing the blood flow. We can go up on that formulation on those strengths. That's one of the benefits, again, of compounding, is that you can think about these formulations as kind of your base menu. You can always go off menu, ask to add something or to remove it, So the customization is there. As a matter of fact, we had a formulation this week for the nifedipine and patoxyphylline, where the physician added in lidocaine to help with the pain that the patient was having associated with that decreased blood flow. A lot of physicians have tried these pain creams for neuropathy and didn't have the best results in the past. Honestly, I didn't love it either. We'll talk about that in just a minute, about why now we feel like it's a better option than it was a few years ago. But our formulation for neuropathy is the amitriptyline, baclofen, and lidocaine. Our patients absolutely love this formulation. We get a lot of positive feedback on this one in particular. One of the Ascend-specific formulations that you probably will not see anywhere else, it's one we created in conjunction with some PCCA consultants and physicians as well, is this Neuroma formulation. Again, the verapamil is in there to help break down that fibroma, to reduce the size of it. And then as well as the tamoxifen, it works as a little different mechanism. It actually is going to inhibit fibroblast proliferation and decrease the collagen production. So we've got two agents in there helping to break down that fibrous tissue that's created, that neuroma. And then the naltrexone that's in there is actually for the pain relief. So naltrexone at full strength is an opioid addiction treatment, but 20 plus years ago, they found that low dose naltrexone actually has immune modulating effects and can actually reset, for lack of a better word, the inflammation process. And so you can get a significant pain relief from that. And then the DMSO is just in there to help penetrate the naltrexone and a little deeper into the tissues. This was a formulation, honestly, we created not really knowing how beneficial it was going to be. It was definitely we know all these pieces should work together, and just kind of said, let's see what happens for patients who didn't want to have surgery or surgery wasn't an option for them. And we have gotten significantly positive responses from our patients. First of the year, we had a patient give us a call back and say, I kind of quit using this over the holidays. And boy, can I tell a huge difference. I want to get it back on it. And he's consistently refilling that prescription since. My favorite pain formulation is the combination formulation. The combination, basically it takes that pain and inflammation formulation with the neuropathy one and puts it all together. I kind of get the best of both worlds. I jokingly call this our kitchen to sink approach with our patients. But it's great because patients don't always do the best at describing what the pain feels like. So one of the reasons patients typically fail topical pain therapy is, maybe they described it more as a tingling, burning, shooting pain when really it was more of an achy pain. And so just the wrong drug selection was made in the first place based off the patient's explanation. This eliminates that possibility. And so this is definitely our most frequently used formula for pain. And then our last formulation in this pain world is the guaifenesin and magnesium combination. Magnesium obviously helps to release the muscle tension, but guaifenesin, when taken topically, is a skeletal muscle relaxant as well. So orally we get the expectorant effect, but topically we do get a skeletal muscle relaxant. So it's great for muscle tension and tightness, cramping. We have a lot of patients who utilize it for restless leg in conjunction with oral magnesium and get a lot of benefit from that as well. So kind of going back to the neuropathy situation I was discussing just a moment ago, with our topical pain creams, typically the patients are going to apply those where it hurts. That's the logical thing to do. But with neuropathy, as you all know, where it hurts may not be where the nerve damage is. And so about 5-10 years ago, we started recommending patients applying it to their dermatome as well. So I'll often have a conversation with patients, tell them, you go ahead and apply it where it hurts, see how that benefits for you. If you're not getting enough, we have them apply it to that dermatome at the base of the spine, essentially cutting the phone line between the foot and the brain. When the patient does that, the positive results that they're seeing is significantly increased. So for those patients that either have tried them in the past so they didn't work, or you've tried them with your patients and felt like you didn't hear much of a benefit, this can certainly open that door back up to utilizing that neuropathy topicals. Some skin conditions we also treat are, we do have a great formulation for fungal skin infections. The ketoconazole, ibuprofen, clotrimazole, and tea tree oil. So we're kind of approaching it from all aspects. You're going to see ibuprofen in almost every formulation we talk about where there's a fungus involved. Ibuprofen at 2% actually acts as an antifungal. Also, it has a synergistic effect with the azoles. So when we add it with the ketoconazole, clotrimazole, etc., you get a 1 + 1 = 4 effect on the antifungal activity. And also, ibuprofen can help to reduce the bioburdens with the funguses. And when we get a little further into talking about with the nail infections, it can actually soften the nail and allow the solution to penetrate a little bit deeper. So ibuprofen is often thought that they're in these formulations for pain, but that actually is all antifungal properties that we're utilizing that ibuprofen for. This first fungal formulation, we did create it as a gel to reduce the amount of moisture that we're adding to the area. So a lot of times we see those antifungals as creams. So this one we did as a gel for that maceration between the two toes specifically was what it was created for, but we do see it as a benefit for any type of topical skin infection. We do have a spray for some of our practitioners prefer it as just a solution where they can dab this on almost like a deodorant for the hyperhidrosis. Aluminum chloride is fantastic. Obviously, it is what's the active ingredient in most of the deodorants we utilize. But you can also add clotrimazole and ibuprofen as well if there is a fungal component. It's not listed here, but we also do have a glycopyrrolate formulation where that can be utilized as a cream or solution for hyperhidrosis as well. Kind of think about it as your everyday kind of a mild to moderate situation. You would want to use something like the aluminum chloride. For the more severe cases, the glycopyrrolate is definitely an option as well. For our warts, we have a couple of formulations here. The fluorouracil, sal acid, cimetidine, and tretinoin is definitely our most popular formulation, and we see most commonly written. The tretinoin in there, I get asked a lot about why that gets there. The thought process behind tretinoin in there is that it actually alters the characterization of the skin, and so it actually can help the new healthy skin grow and kind of fight the wart out. So we do have patients apply that one at bedtime, cover it, just like we do anything else. Typically, we would recommend using the duct tape, but we also have them, they may also utilize the medical tape over that as well. That formulation can be altered to remove the fluorouracil and tretinoin for patients who are pregnant and get it just a sal acid cimetidine for combination. That's one of our frequently requested alterations there. If the cream's is not working well, or it's a larger wart, kind of more of a plantar situation, the fluorouracil and sal acid in the DMSO is a huge benefit. So it's going to penetrate deeper into the tissues than the cream does. So those warts that are more difficult to treat, that DMSO solution may be your better choice there. And I do see a question about the Neuroma formulation for painful scars. It could be utilized in that way, but we also have this scar formulation. This scar formulation was created kind of to be used for old or new scars. So you do have the verapamil in there to help break down the fibrous tissue and or prevent keloids. The pentoxaphylline and triamcinolone are great for prevention of scarring as well, but you do want to not use that on a brand new incision site. We do want to make sure it's healed before we add those on, because they can slow the healing process if we use them too soon. But they can also be utilized on the outside edges of that as well. So that's kind of one of those, you have to be cautious when you apply it, and how quickly you start it after an incision. But they usually can be used once the incision has healed. And then you also, again, have the lidocaine in there for pain, and the hyaluronic acid is there for moisturizing the skin to, again, help prevent that scarring. Our nail and wound treatments, this is one of my favorite areas, just because it's been where I've lived for the last several years. As it was said earlier, for several years, I have worked with podiatrists throughout the country, where they would send me their DNA lab results, and I would make a recommendation back to them based on those results. What we saw most frequently was that in about 85% of the cases, there was a bacterial component as well. And in some cases, only a bacterial component. We never saw fungus present in those infections. So that was a big shock to me. In pharmacy school, we were taught that a nail infection was a fungal infection. And so those statistics really were surprising to see. So our most frequently used formulation is that ketoconazole, itraconazole, and linezolid ibuprofen solution. That is what we saw most frequently needed from those DNA results. So if you're not doing a culture, that's kind of a good all-encompassing formulation. If you're confident that it is just a fungal infection, we do have that itraconazole ibuprofen as well. And then for those that you need to actually remove the nail, or we have a thickened nail situation, we have the urea 40% itraconazole ibuprofen ointment. We do have the patients, apply that at bedtime and make sure that they do cover that with a Band-Aid. We've had a situation where patients have not covered it and spread it onto the skin and gotten some significant sloughing of the skin surrounding the area. So that is one of those things we definitely counsel our patients on, making sure they've covered that to keep it on the nail to be treated. Here's some visuals of the nail solutions before and after. You can see the yellowing, thickened nails. This was actually a formulation of ketoconazole linezolid. And that was from the before pictures, I believe, were in May, and the afters were in October. So saw some pretty significant results quickly. I also personally used this one last summer, had lost about half my large toenail. And within a few weeks, it was cleared up and grown back. With very sporadic use. So definitely one of the better formulations I have seen out there for nail infections. For those of you that have been in the compounding world for a little while, you will probably remember the foot bath rage a few years ago, where patients were getting a combination of a lot of commercially available products to mix together in a basin at home. What we do instead is the patient gets a capsule. It's a combination of doxycycline, bupirosin, and ketoconazole. Again, the anti-infectives that we see most commonly needed for wound care or nail infections. And then the filler in those 4 capsules is actually xylitol. Xylitol is fantastic at reducing the bioburden. And so we chose that as our filler so that we're getting something beneficial when it could just be an inert situation. So we always try to find the best ways we can to improve our formulations with little things like that. Depending on what you're treating, the patient will get one of the 2 nail basins. One of the 2 basins. The basin on the right is what we will send the patient from the pharmacy if they have a nail or skin infection. Some practitioners like to use this as first-line therapy for a nail infection. Honestly, it's not my favorite. I feel like it doesn't penetrate the nail quite as well to be first line or a sole treatment. It works great in conjunction with one of the nail solutions. But it's also a situation we see used frequently for patients who have had a nail removed or have an all over skin infection. We also see it used quite frequently for diabetic patients who struggle with just good hygiene. That's also a great option for them as well. The basin on the left is something that we would send the patient directly to their home for if they have a wound, because we wanted to find a way to help stimulate the blood flow to this area, as well as help to debride and clean the wound well. Speaking of wounds, we have two different wound formulations. The healing formulation was one that was on board when I came. It's the pentoxaphylline, triamcinolone, metronidazole, itraconazole. This formulation is definitely one that I would utilize with caution. It is a great formulation, but if we are putting it directly into the wound, it can slow things down a little bit. It's one that we want to definitely apply on the outer edges of that wound. It's going to help increase the blood flow and prevent scarring. But again, if we're putting it directly in there, it can impede the healing. So we had some physicians who absolutely love it, so we wanted to keep it on board. But it is one that the application will certainly affect how beneficial it is. The second formulation there under the wound care is a combination. Again, we have the metronidazole and itraconazole there. Those can be substituted out based on any kind of lab results you've done. The basis of this formula is the important part. The EDTA and the polysorb there are in there, again, to reduce the bioburden. It's going to help break down the defense mechanisms of the bacteria that's present. And it's also put into a Pluronic Gel. A Pluronic Gel is one that has got reverse thermodynamic properties. So it's going to be thickened as it warms to body temperature. So it goes on like a cream, but it adheres to the wound more like an ointment. So you get the benefit of an ointment adhering and staying put where we want to. But what's really nice about it is when it's time to clean the wound, it's water washable. So you're not having to scrape an ointment out and do more damage to the wound bed. It also can help to revascularize the tissue, by stimulating new capillary growth. So the pictures below is a patient that we had a few years ago. We used that same basis of the formulation, the EDTA polysorb with the Pluronic base, and utilized two anti-infectives specific to this patient's culture. She'd had a wound for about 18 months that they could not heal. In November, just before she started treatment, she was actually asking her insurance company for a amputation. Her quality of life was poor. She was in significant pain on a day-to-day basis. And so that is where we started with this patient. You can see there on the far left, that's a quarter that they're holding up to it. So larger than a quarter, significant depth to that wound bed. The second picture was about 4 weeks later, and that's a nickel that she's using. The wound bed had it was much more shallow. You can see the revascularization of the tissue and improved blood flow to the area. By the end of January, she had again, much more healing there. And by February, she was able to just cover it with a Band-Aid. The pictures there in January, the patient was already back out and going to the grocery herself, playing with her dogs. Her quality of life had drastically improved. That's just one of those fun. It was actually a coworker that we were working with was her mother. And so just to see the quality of life improvement and how it affected the patient and her daughter was just kind of one of those huge wins. And so we brought that one on board. So like I said, again, that formulation can be altered based on any cultures that you have. And I'd be happy to help give those recommendations as well. We do offer a couple of different supplement options. We have neuropathy formulation. You can see there all the ingredients there. The dose on that one is 2 capsules each day. It is similar to some of the other products out on the market. We just took some of the formulations and tried to simplify it. So instead of having a lot of different options, we wanted to kind of simplify it for our patients and for you for selections. And then we also have a bone support one as well. And we have a combination of calcium, vitamin D, zinc. And then while you won't see magnesium listed as an active ingredient in it, that is utilized as a filler. And that one the patient does utilize 3 capsules each day. So one of the questions we always get is, what's the cost? Obviously, at the end of the day, if a patient can't afford it, it's not going to be, no matter how great it works, it's not going to be beneficial to them if they can't purchase it. So our focus is to try to provide a quality compound at a reasonable price. Because these patients are your patients, are our patients. We want to make sure that they get taken care of. So we try to keep everything in the $50 to $60 range for a month supply is our goal. Nothing on our formulary is going to cost the patient over $100 at this point. We are not set up to bill insurance, and we did that for a couple of reasons. The main reason is that most insurance companies do not cover compounds anymore. If a compound is covered, it's typically a situation where the patient is going to get multiple single NDC drugs, like a Voltaren gel, a Lidocaine ointment, and they're going to have to either mix them at home or apply multiple treatments, and honestly are not going to get the absorption that they need to get the best benefit. But when we accept the insurance, we have to jump through lots of hoops, just like you all know how wonderful they are, and therefore have to really increase our overhead costs. So what we've chosen to do is actually not accept insurance. We are cash only to keep that cash prices as low as possible, but we are happy to provide the patients with claim forms that they can send into their insurance company to see if they could be reimbursed. And honestly, we have seen that the cost is not a huge issue for the vast majority of our patients. When we're able to reach the patient, when we reach out to them, almost 80% of the patients do fill the prescriptions. And we also try to give them, especially with the pain creams, give them a variety of size options so that they can pick the most budget-friendly alternative. A lot of patients do start with what we call our trial size. They get a smaller size that they, for a lower price, and then to see how it works for them. And then typically when they call to refill that, they will get one of the larger sizes at the better value. So some of the questions we get most commonly from our physicians are, how do I apply this to my practice? How do I apply this to my day-to-day? Some simple things are, if you would have recommended a Voltaren, looking at maybe doing that pain and inflammation cream. If Tolsolin is your kind of go-to for a nail infection, looking at something like the ketoconazole linazolid formulations. Other options would be, for like an antifungal cream, you could look at doing the skin infection cream. So pretty simple to do. And when all else fails, if you're not really sure when to utilize it, what to do, feel free to reach out to me. You'll have my contact information here at the end of the slides. And I'm happy to do that. Some of our practitioners that we worked with when they first started utilizing us would literally send me a text message every day and say, hey, I have this situation. What do you recommend? Actually, 2 of our formulations that didn't make it into the slideshow, and I do apologize for that, came out of those conversations with physicians. So we have 2 formulations. One is a urea triamcinolone ointment. One of our practitioners called me one day and said, hey, what do you have for heel fissures? And he was seeing resolution of the fissures in about 2 to 3 weeks. Another formulation we have is a urea 20% in a base called Zematop. And that's kind of goes back to the reference to PCCA earlier in the evening. The Zematop is a base that was designed specifically for dermatologic purposes. It is used to replenish the lipids within the skin. It helps to nourish the skin's structural integrity, and we restore the tissue while maintaining the moisture barrier and preventing water loss. So we see that as a phenomenal formulation for calluses. We just had a patient call this last week to refill and said they had utilized 4 or 5 different commercially available treatments over the last few years for their calluses and hadn't gotten anywhere. And this was the first formulation that they had utilized that had actually gotten them some resolution. Something else that we'll see with when patients come in, one of the questions we get a lot is beyond use staining. We are a USP certified, we have to follow USP standards, I apologize. And that limits what we can put on there for beyond use staining. Anything that is a water containing base, we can only put 30 days on there. We do have patients that utilize them well past that. But we always tell the patients on the front end, this is a 30-day expiration date. Most patients understand that and will then select the size that's most appropriate to them. Others just utilize it beyond that date and still get the same benefits. Things like ointments, the nail solutions, capsules, things like that have a longer beyond use date because they don't contain water. So they're usually good for more like a 6-month period. We've already addressed the insurance coverage and cost. Recently, we did a study or survey of the patients who have utilized Ascend in the last 6 months to a year. And as you can see, almost 70% felt like the utilization of a compound was improved. Their health was improved by the utilization of that compound. Our staff, loves our patients. We take great care of them and try to do our best to answer any questions they have. We will work with them to try to find options. If the treatment option is not working for them, we'll work with them to reach out to you as a practitioner to see if there's something we can do to improve that formulation. And about 62% of our form patients also feel like they'd be more likely to recommend their podiatrist or someone else because of the treatment they received from us. So if after all this, you're interested in utilizing Ascend, you can go to our website. There is a page on there for providers. You can simply put in your information and you will get a customized prescription pad sent over to you. You can also get some instruction cards. Those typically are really great when handed out to the patients. They give them a heads up that they're going to hear from us and to know that that's to look for us to make sure they answer that call. And it gives them some more information. We also have some flyers that can be put in the exam rooms if you're interested in those that lets the patient know, hey, there's a treatment option out there for something they may not even know that they could treat. One of our patients read about hyperhidrosis on a sign and didn't even know there was something that could be done for it. They just thought that they had to live with having sweaty feet. And so puts drives the patient to take some responsibility for their care. As always, I am here to answer any questions and to help customize the treatments based on anything that you need. My information is there below. And I think that's about it.
Ashley, thank you so much. I learned quite a bit, and we actually have quite a few questions already in the queue. So I'm gonna get started, and Andy and I can bounce back and forth, and then I've got a couple of other questions on my own that I thought of that I wanted to ask you. So, can you add nitroglycerin to your Rainoist formulation? I used to use nitro for Chilabands and Rainoids a lot, but cannot get topical nitro anymore.
It could potentially be added. We have to use nitroglycerin in any of these compounds. We actually have to use nitrobid and dilute that down. So I'm not sure how well that would penetrate and how well it would go into a cream solution, into the cream and be incorporated into the cream. But we could certainly look at doing that. If you want to shoot me an email with something, we could play with that information and see if that's something we could do.
Great. Can the Neuroma formulation work for painful scars?
Yeah, I think that's something that could be certainly utilized. We do have the scar option as well, but I think the Neuroma formulation would be perfectly acceptable to be used for a painful scar.
And do you have a formulation for keratodermas?
Not that I know of. So that is one that I certainly will look into doing. And if you want to shoot me an email, I'll do some research and we can see if we can come up with formulation.
Great. So I have a question for you.
Yes.
I know that you're a cash pharmacy, and I know that you have multiple different sizes for the patients. Do you guys do an auto refill program? So if a patient is using something and they have an opportunity to sign up for an auto refill because sometimes they forget, they run out. What do you guys do with that?
We're working on that. Transparently, that is not something we have done. Our software has not been the best for that. But we are currently actually working on bringing someone on board that will take over and build an auto refill program. So that is coming in the very, very soon.
Okay. And I know that you talked about doing the compounds. Do you, are there any situations where patients might get multiple tubes of medication and have to mix on their own? Or do they need something that they can put on one tube only, or whatever they're doing? You know what I'm saying?
Yes, sir. I've been around compounding for a long time, so I know that when compounding wasn't covered, it was cash only. We went from when it was covered all the time and got great reimbursements to the multiple NDCs.
Okay.
If you write for a compound, the patient will get exactly what you wrote. It will be in one tube, and it will be a single product.
Perfect. So, do you have a model for physicians to stock any of these products in their office to sell them? Does it have your? It's a multiple question, so I'm going to ask all the questions and let you answer them. Will it have your pharmacy label, or can they private label it for their practice? And can you remind us which products are the water-based products?
Okay, so water-based products, we'll start there. Those are all the creams, or like a hyperhidrosis solution. So those are going to be the things that have that 30 days on there. Unfortunately, with compounding, there's not a model for being able to stock it in the offices. They do have to be made patient specific. And so that is something that it has to be written directly to the pharmacy. Unfortunately, there is not a way to be able to stock it in the physician's offices.
So it's not something that's pre-made. It's something that is made especially for that patient via a prescription, and it's not something that offices can have on hand and dispense.
Correct.
Okay.
And kind of that leads into another question that we get a lot. And I'll just kind of jump in there is how quick, what's the turnaround time? What does this look like? If you were to send a prescription, what happens? Typically when a prescription is sent, we reach out to the patient within 1 business day. Sometimes we even catch them while they're still in the office. So just depending on our flow, but typically the patient is reached out to within 1 business day. Once we get a hold of the patient and the patient says, yes, I want to get it, it's usually takes up to 2 business days to compound. And then depending on where the patient is, that can usually take, up to 2 days to get it to them. So typically you're looking at a 4 to 5 day maximum turnaround for a patient. So certain formulations we obviously know are more important, gout, wound, things like that. We try to get out as quickly as possible.
Now I have a question. I noticed when I heard early on, Dr. Bhatia mentioned that you were licensed in 16 states. Are those the only states that you're able to service at this point right now, or do you have the ability to do you have other staff pharmacists that you're able to do work in other states?
So the pharmacy actually has to be licensed in states for the pharmacy to ship anything there. So currently we are licensed in 7 states: Pennsylvania, Indiana, Tennessee, Kentucky, Georgia, Alabama, and Florida. So those are the states we can currently ship to. We are working to increase that. So if you are a practitioner in a state that is not listed and are interested, please let me know. And we can make sure that that state gets added to our list of licensure that we're working on.
Okay.
Did you already mention this one, Ira? Is it also true that for your neuropathy, is that true also for your neuropathy supplements that you cannot stock it in the office?
Correct. The compounds cannot be stocked in office at all, unfortunately.
Okay. What is the turnaround time anyway?
It's about 4 to 5 business days from the time we receive the order till the time it's in the patient's hands, at most. Sometimes it's shorter, but that's the maximum typically.
So I have a question. So can patients get like multiple medications they have mixed themselves?
We don't do that. Typically, they're going to get just the compound just from us, so they don't have to do that.
Okay.
So I've got a curious question, Ashley. When I was in practice, one of my favorite wound care products on the market was pulled off the market. It was called Panifeld Ointment. It was a papyurea. It was probably one of the best wound care products that I'd ever used. And I thought it was a joke, the reason why it was pulled off the market. I did have somebody in Chattanooga who used to compound it for me. But do you have any, obviously you shook your head, so you know what I'm talking about. Do you have anything of that quality or something that matches that type of product?
Unfortunately not. And the reason I'm shaking my head is because I agree it was a great formulation. But it is with compounding, there are certain drugs that we can and cannot compound with, and those are on the list that we cannot compound with. Another question we get a lot with wound is, can you compound with collagenase? Unfortunately, it's seen by the FDA biologic. We cannot compound with it. We can do the other formulations, and you can utilize Santal in conjunction with it, but it's not something we can actually compound for it.
Yeah, and you might probably know better than I do. My understanding was that there were really no issues with the product, but it was out before they did FDA certification, and then they required certain things with FDA certification, and it would have cost them a fortune to get the testing or do the clinical trial that they needed for a product that had been used for years already with great success.
Yes, and so for compounding, that kind of the same kind of rules is that if it doesn't have a USP monograph or isn't part of a commercially available drug, then we can't utilize it. So there's kind of what we call the yes list and the no list, right, in compounding world. And so if it's on that no list, unfortunately, we can't utilize it.
Okay. Well, I don't have any more questions, and I think I've asked everyone here that's on the list. Andy, do you have any additional questions that you would like to ask?
Not
we don't always have to go the whole time. What?
I'm taking no, not at this time. That was great.
Ashley, are there any pearls that you might have for people that are considering bringing in compounding into their practice? I know that certain times there's ways to present this to the patients. I'm assuming that Ascend has some educational material that we actually can give to the patients. Is there anything that you recommend on how they can roll this type of program out with their patients?
Yeah, absolutely. So what we found has honestly been the best thing is for when the physician just tells them there's a customized medication we feel is the best option for you. The pharmacy is going to reach out to you, and they'll go over everything with you, the cost and all of that with you. Honestly, that's been the best approach. We have some of our best writers, just that's simply how they handle it is, this is what I feel is best for you. We're going to send it. The pharmacy will reach out to you, and they'll take care of everything from there.
Great. Well, Ashley, it was an absolute pleasure having you on here tonight. Believe it or not, I've heard a lot about you for a long time. It's all been wonderful. But anyway, I want to thank everybody for joining us on Taylor Tuesday. It's something that we enjoy doing. It's been fun. We try and educate people with everything that's going on. For those of you who are interested, next week we have an amazing speaker. Dr. Mary Beth Crane is going to talk about physician burnout as an epidemic and what we can do about it. 2 weeks. I'm sorry. Thank you, Andy. I forget we do it every 2 weeks. But anyway, again, I want to thank everybody for joining us tonight. Ashley, it was an absolute pleasure. I know Siobhan will send out an email forwarding all your contact information to everybody, and we hopefully will see you again sometime.
Absolutely. Thank you so much.
You're welcome. Everybody have a great day.
Bye. Thank you. Take care.